Okay. Bismillah ar-Rahman ar-Rahim. Good evening, ladies and gentlemen. I would like to welcome you all in our webinar, Salt or Sodium and Hypertension. And I would like to welcome Professor Sheldon Tobe. Uh, Professor Sheldon is a distinguished speaker. He is a professor of medicine from University of Toronto and Northern Ontario School of Medicine. He is director of postgraduate fellowship program in adult nephrology from University of Toronto. He will talk to us today about the controversy of sodium and hypertension. Mainly, he will concentrate on three main topics: sodium, blood volume, and hemodynamic stability. Sodium, is it too much of a good thing? Is it harmful? Who is at risk of develop increasing blood pressure in regard to high sodium intake? And what is the controversy about maximum daily intake of sodium? So, Professor Tobe, kindly, the floor is yours.
Thank you very much, and it's a pleasure to talk with you and to work with you together in Saudi Arabia. Thanks to Dr. Tawfiq for making this possible and for continuing our very exciting collaboration. This topic is one that I really enjoy, and I'll tell you a little bit about the background. When I led the hypertension guidelines in Canada for many years, from 2005 to 2012. And one of my good friends and colleagues, Norm Campbell, is one of the most aggressive reduced sodium advocates in the world. And I work closely with Norm on the guidelines group, but also through my research, I also participated in clinical studies with my friend Salim Youssef from Hamilton, Ontario, and we published some work together. And suddenly in 2012, 2013, Dr. Youssef had some new data suggesting that low salt maybe wasn't good for patients. And there's this controversy. And both are very focused men and very strong-willed. And I was actually on the stage between them at a talk and a debate that they both gave. It was very heated and a little bit uncomfortable for me to be in between both of them. And really what we have is a controversy about too much salt, too little salt, and really the controversy is around how much salt is the right amount for us. And both Dr. Youssef and Dr. Campbell are right. And it's just when they get into one very small area, that's where the disagreement is. So we will review that today, and I hope by the end of the session today that you will be comfortable knowing what the answer is. So the bottom line, the slides are coming through okay?
Yeah.
Excellent. If you're tired and you want to go to sleep and you just want to listen for 5 minutes, here's the bottom line, and this is what I'll talk about. Sodium intake and population health, there's no question that too much salt intake is not good for us. Also, too little salt intake is bad. And that's why in the past, in ancient times, salt was considered like money. It was extremely valuable because we have to have some salt. Our bodies rely on it. The only way to do a proper study on sodium intake, because understanding what people eat in their diet is very difficult, is to do 24-hour urine tests. But that's hard. And people don't like to do 24-hour urine tests. They don't collect the tests well. And if you're doing a lot of patients in a study, a few thousand patients, it's very unmanageable to do 24-hour urines. But anything but a 24-hour urine test is going to lead to inaccuracies. Is a reduced sodium diet for everybody? We'll talk about that. and we'll talk a little bit about salt-sensitive hypertension. We'll review some areas of agreement and some areas of disagreement. And we'll talk about the sodium advice we should recommend to our patients. The bottom line for me is for patients who have high blood pressure, kidney disease, heart failure, diabetes, we want them to be on a low sodium diet targeting 2,300 milligrams per day or less. And for everybody else, if you're normal, try not to overdo it. Try to stay less than 4,000 milligrams per day. Okay, let's go through the evidence. So, salt sensitive. Here's a middle-aged man, and he is a salt sensitive patient. He's 55 years old. He notices that at the end of the day, if he's been indulging in fast foods and in a lot of pizza, if he's been using too much salt shaker on his food, when he takes his socks off at night, that he's got some swelling. He's diagnosed with hypertension 2 years ago. Both of his parents were hypertensive, also at the same age, and his brother is hypertensive. He's the classic patient with essential hypertension, and now that he's old enough, he has also become salt sensitive. All right, so today, this evening, we're going to describe the role of sodium in maintaining normal blood volume and hemodynamic stability. We're going to talk about the evidence that too much sodium is harmful, and the population groups most at risk from excess dietary sodium. And we'll talk about at length about the controversy about the recommended maximum daily sodium intake and what the ongoing debate is really about. First, salt and sodium. Sodium chloride is a salt, and we're going to focus today on sodium. I often say salt instead of sodium. I will try to stick to sodium. And this is a practice point when we're talking to our patients about reducing salt in their diet and sodium in their diet. We want them to focus on sodium because that is what is on the food labels. So if you tell them to go to the food label and look for salt, they won't find salt, they'll find sodium. So we want to teach them about sodium, and 1 teaspoon of salt is about 5.8 grams, that's sodium chloride. That's 100 millimoles, and that's our target for patients who have chronic illnesses like hypertension, diabetes, heart failure, and chronic kidney disease. Our target is 2,300 milligrams of sodium per day. Most people can do that if they cook all their own foods and prepare all their own foods. But for most of us, 80% of our food, of the sodium in our food, comes from fast foods and processed foods. In North America, most of it for adults is coming in bread. For children, it's coming as cheese. And it's only 10% that we're adding at the table with salt from the salt shaker. It's perfectly reasonable to cook with salt, to cook with sodium, to make our food taste good. But what we need to do is to teach our patients how to reduce the sodium intake that they're getting from fast foods and processed foods. Here's an example. Here's some data that I was able to find recently. The Journal of Food Service Business Research, not a journal I normally look at, but it had some very interesting data, and it compared sodium content in foods from around the world, from USA, from the Arabia region, so appropriate for you, and from Australia. So not Canada, but Australia. And if we look through USA here in the left column, Arabia in the middle, Australia to the right, and they compared fast food from 3 outlets, McDonald's, and they compared the Big Mac. And the first thing that we see is that there's a huge amount of sodium in this food. One Big Mac has almost 1,000 milligrams of sodium. That's almost, for someone who has hypertension or chronic kidney disease, half of the recommended daily allowance. The second thing you see is that the amount of sodium in these foods varies considerably. I don't know why a crispy McChicken in Saudi Arabia has double the amount of a McChicken in the USA, or why a Big Mac in the USA has more sodium than in Australia. I can't explain that. Similarly, for Kentucky Fried Chicken, 3 yummy crispy strips of chicken has a lot of sodium, but much less in Arabia. And similarly for pizzas, you get off well in your country, whereas in the United States, the amount of sodium in a pizza, that's one slice of pizza, is quite high. And who can have just one slice of pizza? So if we have 2 slices of pizza, we're up at half of our recommended daily allowance. So the bottom line on sodium intake, in most countries, sodium intake is high enough that many people without high blood pressure, without hypertension, are going to develop hypertension earlier. And they're therefore at higher risk of more years of exposure to hypertension. So someone whose parents, like the patient I mentioned at the beginning, parents, one or both parents has hypertension, that person is more likely to develop hypertension over their lifetime than someone with no family history. So that's the genetic component. But that interacts with the environmental component by the amount of sodium in their diet. So if there's more sodium in their diet, they're likely to develop hypertension at an earlier age. Let's say they develop hypertension 5 years earlier. That's 5 more years of exposure to hypertension. That means that the downstream risks of uncontrolled hypertension, heart attack, stroke, dementia, and so on, atrial fibrillation, are more likely to occur at a younger age. Also, people with hypertension, if they're eating a lot of sodium in their diet, their blood pressure is more challenging to control. They need more medications because the sodium impacts on the effectiveness of most antihypertensives. So it's important for most people to know how much sodium they're eating and to avoid excessive salt intake. All right, let's go into the background. Let's start with population health. Too much sodium causes and worsens hypertension. So there's incontrovertible evidence for this, and really no one is disagreeing. And both sides of the salt controversy agree on this data. Too much salt is no good for us. I'm going to take you through some very recent data that comes from the United States. In fact, the public health in Canada teamed up with the United States and came up with this new reference intake for sodium. And I recommend look at this reference, take it down. Thanks, Dr. Tofik. I have sent you the slides, and you're welcome to distribute these slides out to everybody. So the references are here. This is an excellent resource. It's about 150 pages, all about the whole sodium controversy and a review of all the evidence. So I've taken some highlights from this new information. The most common source, as I mentioned, of sodium for adults is bread, pizzas, cured meats, and poultry, like Kentucky Fried Chicken. For children, cheese is the #1 source of sodium. So for a child who's with both parents being hypertensive, we would want that child to have less sodium in their diet. It's difficult to assess the minimum or maximum levels for sodium, and this group has assessed the same for potassium. Well, for potassium, it's easier, but for sodium, they point out that there's no biomarker for sodium requirements in the general population. We require sodium in our bodies. That's what keeps our blood pressure up. That's how we manage to stay upright during the day. We have enough sodium, it makes our cells swell, and we have normal tissue turgor, and we feel good because we have sodium in our bodies. And sodium potassium ATPase helps to regulate the amount of salt, the salts in our cells. So our blood volume is, and our extracellular fluid is dependent on sodium. We want to maintain a sodium concentration of 140 millimoles per liter and multiply that by the volume of the extracellular fluid, and we require that much sodium in our bodies. So we all need sodium to stay alive. if we become volume depleted, when we come into an emergency department, the first thing they do is start an intravenous and pump us full of normal saline to bring our blood pressure back up. Okay, but we're not talking about acute management here, we're talking about chronic management. And if we take our system that is dependent on sodium and remaining with good tissue turgor and good blood volume, and then add a little bit of extra salt to it continuously every day, that's when we can get into trouble. But not everybody gets in trouble. So there's no biomarker for sodium requirements. Sodium balance studies are really difficult to do because our body has all these different rhythms. We know if we eat a heavy salt diet, we might be up all night going to the bathroom. But some of these cycles can last over 24 hours. So if we give a salt load today, it's not like it's all going to be excreted tonight. Some will be excreted tomorrow morning, some tomorrow evening, and some even 2 to 3 days from now. Because of all of this, they felt they could not calculate a recommended dietary allowance. So instead of a recommended dietary allowance, they targeted two things: a minimum level. So they called their minimum level adequate intake, or AI. And that's the minimum intake based on the lowest value in trials. And they noticed from these clinical trials that at the very low sodium target for these trials, people didn't come to any harm from being on the low sodium diet. So they took that lowest sodium level and said, okay, that will be the adequate intake. We want everybody to have at least that much sodium in their diet. And for men and women, age above 14 or above, that is 1,500 milligrams per day. Not a lot of sodium. And we'll talk about at the end that there are some patients that can get in trouble if they have less than that amount of sodium. And it makes up about 1% of our population. So there are people that we don't want to go less than this in. But for the 99% others, if they have less sodium than that, they'll be okay. But this group came up and said 1,500 milligrams per day, that's the lower limit. We don't want anybody to go below that. And then the CDRR is the chronic disease risk reduction intake value. So for patients with these chronic illnesses, hypertension, cardiovascular disease, chronic kidney disease, diabetes, and heart failure, we want patients to be around 2,300 milligrams per day or below. So if their sodium intake is beyond 2,300 milligrams per day, it's up around 3,000 or 4,000 milligrams per day, we want them to reduce their sodium intake to around 2,300 milligrams per day. So, okay, how many people are actually achieving these levels? Well, let's look. So we have these charts, men on the left, women on the right, and we've got they've got data for both Canada and the United States, and it's quite interesting the difference between the two countries. So the AI, or the lowest threshold, the adequate intake, we want people to have more than 1,500 milligrams per day. In the US, 99% of the population is taking more than 1,500 milligrams. In Canada, for men, 97%. In the US, 99% of women. In Canada, 92% of women. And in clinic this morning, I saw a couple of these women who said, we had a heat wave just a couple of days ago. I don't know if you'd consider it a heat wave in Saudi Arabia, but it was up around 28, 29, 30 degrees for a couple of weeks. And everybody in Canada was very hot in my part of the world. And my patients who have a very tight sodium diet actually felt a little weak and dizzy. Okay, what about the CDRR? This is that 2,300 milligram level. And just to remind you, CDRR stands for chronic disease risk reduction intake value. So we want our patients who have chronic kidney disease, hypertension, diabetes, or heart failure to be around this 2,300 milligrams. And what about how many people in the US are exceeding That amount, 97% of men, 80% of women, and in Canada, 80% of men and 46% of women. So lots of people eating too much sodium, particularly in the US. Now, 4,000 milligrams per day. Half of American men are exceeding that level, but only 6% of women, and not that many Canadians are up above that level. And 5,000 milligrams per day, it's only 20% of men, 5% in Canada, and very few women are eating that much sodium, at least in Canada and the United States. So there's a bit of a background. That's where we're at today, and these are the current recommendations that have just come out. So let's look around the world. This data comes from 2013, and this is data that was taken from a whole bunch of clinical studies that used different methods of assessing sodium intake. Most of it was spot urines, some was dietary assessment, and some was 24-hour urine assessments. But around the world, you can see different levels of sodium intake. The US is a little darker green than Canada, as I showed you, eating more higher sodium intake there. And the Arabian Peninsula doing pretty well with sodium intake. China not doing so well. Same with Japan, higher intake of sodium. And there are, Alberto did this meta-analysis in 2013, looking at how well we're doing with blood pressure lowering from sodium. Does reducing salt in the diet, does reducing sodium in the diet lead to reductions of blood pressure? So the answer is yes. So this big meta-analysis was conducted, and we're looking at 3 different areas on the forest plot. So there's very low sodium intake, less than 2 grams per day. So heading down towards that adequate intake versus more than 2 grams per day. Here's the diamond showing about a 3 millimeter difference in systolic blood pressure. Less than 1.2 grams per day, so really low, less than the adequate intake versus more. Even going down that far, hypertensives have a reduction of blood pressure. And if you take someone and cut their sodium intake by 1/3 versus just leaving them alone, you also get a nice reduction of blood pressure. So yes, lowering sodium in the diet does reduce blood pressure in hypertensives, and these were really going to very low versus just low sodium intake. Now, the PURE study. So the PURE study is where things started to get interesting. There was no sodium controversy before PURE. So PURE starts out, well, from a sodium intake. Sodium intake is based on the spot urine. So rather than collecting the urine for 24 hours, you just take one sample of urine. You get a urine sodium to creatinine ratio, and you can estimate from that the 24-hour sodium intake. Of course, it's an estimate. And of course, the patient could have been on a diuretic, and they could be in their diuretic phase or their anti-diuretic phase. It could be first thing in the morning when the patient is anti-natriuretic, or it could be after a big meal. So a lot of variability. But when you go to 100,000 patients, okay, you start to, over 100,000 patients, that variability is going to even itself out. And so that's pretty impressive. And thanks to Salim Yusuf and his group at the Population Health Research Institute for coming up with this data. Now, they found what everybody's found before. Higher sodium intake is associated with higher blood pressure. Every 1 gram, 1,000 milligram addition of sodium raises the blood pressure overall, hypertensives and normotensives together, by about 2/1 millimeter of mercury. Okay, so you're not surprised, and that just reinforces everything that we knew before. And they produced these graphs in the New England Journal of Medicine. On the x-axis here on the left is the urine sodium excretion. We have from 3 to 5 grams per day on the bar chart. And we see that they're and way up to 5, all the way up to greater than 10 grams per day. I don't know who's eating 10 grams per day of sodium. They must be eating salt out of the salt shaker and consomme soup. But there's a nice, and the y-axis is systolic blood pressure, a nice linear response to blood pressure. And the patients in the open bars are patients from China, and only in China would you see patients up around 10 grams. And the rest of the world is in black here. And okay, so nothing surprising there. And we'll look over to the right. And on the x-axis is the number of millimeters of mercury increase. And really, it doesn't matter if someone is eating 3 to 5 grams or 5 grams per day. The more sodium they eat, if they're under 45 to 55 years old or over 55, their blood pressure is going up. Of course, the older they are, the more likely they are to have higher blood pressure from that. If they have no hypertension, their blood pressure still goes up, but only a little bit. If they're hypertensive, then and they're in the higher sodium group, their blood pressure goes up a lot more. And then they plotted sodium intake or sodium excretion from their sample, and the odds ratio of a bad event of death and cardiovascular disease. Now look what happens. There looks like there's a U-shaped curve, and people with a lower amount of salt in their diet now have an association with worse outcomes. And here's most people in the middle, from 2 to 6 grams per day, and above 6 grams, clearly a relationship. The higher sodium intake is associated with worse outcomes. But for the first time, we see that Martin O'Donnell shows that this low sodium intake seems to be associated with bad outcomes. Now, the study has 80,000 people, and only 1,800 people make up this lower amount. So who are these people? Are these people who have been put on low sodium diets? Are they people who are sick, who have cancer, or who have severe heart failure? Well, we don't find out. And as I'll show, when this group shows us information, they say, we have more data like that, and data from OnTarget and Trend, 2 studies that came out of the PHRI. These are both blood pressure studies. OnTarget compared ramipril to telmisartan versus both, and Trend was telmisartan versus placebo. I was involved with both of those, and I did a nice publication with this group on another aspect for the OnTarget study. Also, this group with 28,000 people shows a nice U-shaped relationship between sodium excretion and the hazard ratio for cardiovascular death. And again, it bottoms out here around 4, but below 2 grams per day, there's something going on. Now, again, we never see the urine, we never see the serum albumin, we don't see the socioeconomic status. We don't know who these people are in these analyses. And then they put the OnTarget and Transcend together with the Pure study, and now they're talking about 135,000 patients from 49 countries. One of the biggest data sets assembled to look at sodium. And overall, too much salt, too much sodium in the diet is no good. It raises blood pressure. Okay? There's no question about that. Now, let's compare those patients in the middle with intake of around 4 to 5 grams per day. Don't forget, this is an estimate based on the spot urine. So estimating 4 to 5 grams per day, and that's about 25% of this big population. Hypertensives who are taking in over 7 grams per day of sodium, they make 11% of this large 4-study population. Clearly not good. 23% increased risk of bad outcomes. There's the confidence intervals, 95% confidence intervals. If they're hypertensive and they're taking less than 3 grams per day, also, it appears that these patients aren't doing well. What about normotensives? Normotensives, more than 7 grams per day, it does not show a harm, but normotensives who take in too little sodium per day, who are taking less than 3 grams per day, they do come to harm. Now that makes up only 11% of the population. So one of the factors that comes from the study, it suggests that there's this reverse epidemiology. Something's going on where there seems to be a group of patients that with low sodium intake, it's associated with worse outcomes. So let's think about what might be causing that. But let's not forget that in this huge population of over 130,000 patients from 49 countries around the world, that only 11% are taking in a diet less than 3 grams per day. So the CDRR that I was talking about before of 2,300 milligrams, very few patients worldwide are actually achieving that. And the reason that they're not achieving it is that there's so much sodium put into food by the food industry that unless you make all of your food at home and are very careful, very few people can actually achieve that level. So who are this 11%? We're going to get some insights onto that at the end. Okay, so let's summarize our data so far. Too much sodium is harmful, there's no question. Greater than 7 grams per day for hypertensives is associated with worse cardiovascular outcomes. Too little sodium also seems to be associated with worse outcomes, but it's not broken down. Is it less than 1.5? Is it less than 3? We don't know which of those patients had malnutrition, were on diuretics, had heart failure. We don't know their socioeconomic status. If you don't have enough money to buy enough sodium to get to above 3 grams per day, that would certainly be associated with worse outcomes. Similarly, patients who can't eat because they have cancer or they're very sick with heart failure, we might be picking up on malnutrition. Okay, does reducing salt in the diet improve blood pressure and cardiovascular outcomes? Is it for everybody? So let's go back to that meta-analysis by Alberto, and the sodium less than 2 grams per day versus greater. That was the DASH diet. So that's patients who have hypertension. Many of those patients had chronic kidney disease. No question that lowering sodium led to better systolic blood pressure. And as we pointed out, the very, very low sodium diet can lower blood pressure as well. What about chronic kidney disease? So there's some interesting data for patients with chronic kidney disease. So they took a GFR CKD stage 3 to 4. That's an eGFR between 15 and 60 mils per minute. They gave them all a low sodium diet. They kept them on this low sodium diet for 3 weeks, 60 to 80 millimoles per day. So very low sodium diet. Then they randomized them, and it's a crossover study. So they get randomized to getting 120 milligrams of sodium per day or placebo. And they are on that diet for a period of time, and then they cross over after they've had their assessment of blood pressure. So for all those folks, their baseline sodium intake was 126. So if that gets cut in half, then they add back sodium. What happens to them? These are all patients with chronic kidney disease. On the higher sodium diet, their blood pressure over 24 hours is definitely higher than when they're on the low sodium diet. And these are all the same patients. Not only that, their albuminuria dips, and their aldo and renin levels also dip. So these patients with chronic kidney disease seem to be healthier on the lower sodium diet, and their blood pressure was 10 millimeters systolic lower. So patients with chronic kidney disease, no question, they respond nicely to a lower sodium diet, and their physiology looks better. Are there any long-term studies demonstrating that lowering sodium in the diet not only leads to better blood pressure control, but to better cardiovascular outcomes? No. Here's the meta-analysis, and this comes from the Cochrane group. and 2014 review. So putting all of the sodium lowering studies together, and there's not a lot of them, unfortunately, we need more. And these are for normal intensives. The diamond and the forest plot is right straddling unity, so no improvement in long-term mortality. Even for hypertensives, from the few studies that were done with small patient numbers, we're not seeing an improvement. So maybe lowering sodium in the diet of hypertensives will make a difference. But with these few studies, 1,600 versus 2,000 patients was not enough to show the benefit. We really need larger, better done studies. But presently, we cannot say that lowering sodium in hypertensives leads to long-term cardiovascular benefit. Okay, so what are our areas of agreement? Too much sodium is bad. It's no question it's associated with worse cardiovascular outcomes and higher blood pressure. And we're talking about greater than 7 grams per day. But we really need more studies to demonstrate that lowering sodium in the diet in those patients who are on high sodium diets is associated with improved cardiovascular outcomes. Many of the studies I showed you in this meta-analysis compared low to very low sodium diets. And since only 11% of the population are down there, it's really irrelevant to most of our practices. We want to know for patients who are on high sodium diets, more than 4 grams a day, more than 7 grams a day, does reducing sodium lead to improved cardiovascular outcomes? I think that it will, but we need the data. Just a gut instinct isn't enough. Controversy. What is the optimal sodium intake? And can sodium intake be too low? So let's talk about some newer data. In Japan, a study called Esprit was done. And I'm going to take you through this in a little bit of detail because it gives us some insights into the controversy that came up from the PURE study. All right, so let me take you through it. 520 cardiology patients, single center in Japan. Good follow-up though, 5.2 years. And over that time, patients get an average of 14 urine samples done over the 5 years. So 14 of their spot urines are not 24-hour urines. The primary composite that they're looking at, hospitalization for heart failure, acute coronary syndromes, cardiovascular events, cerebrovascular events and cardiovascular deaths. Okay, good primary outcome. Small study, 520, single center. Here's the results. There is, for those patients who have more than 2.5 grams of sodium intake a day, there's a linear relationship with sodium intake, and there's a cutoff at 4 grams per day when, although it says P of 0.4, here we have primary outcome by estimated sodium excretion greater than 4 grams per day, these two bars here, versus these two bars here, the adjusted hazard ratio, 79% increased risk of the primary outcome, and confidence intervals are such that this is statistically significant. So again, higher sodium intake shown over 5 years associated with worse outcomes compared to moderate sodium intake. These are patients who were recruited from cardiology clinic. They all had some sort of cardiovascular disease, but it was quite heterogeneous. And a good chunk of those patients were hypertensive. Oh, but wait a minute. What about this? What about this group? Less than 2.5 grams per day. Here's that reverse epidemiology again. Now look, the total population is just over 500, and there's only 35 of those patients who have less than 2.5 grams per day. But who are they? Now, Sadanaga and his group fortunately tell us who these patients are. Who are these 35 patients? So this is the kind of information I would have liked to see from PURE. First of all, they're older, 78 versus 73. They are lighter. They're slight, frail people. 49 kilos versus 61 kilos. So that makes me think malnourishment. BNP is higher. Predisposition, maybe they've got more heart failure. And their GFR is significantly lower, 57 versus 64. So as I expected, patients in this lower group, and likely PURE and the on-target study are picking this up, is picking up a group of patients who are malnourished, who are sick from chronic kidney disease, sick because they have heart failure, they maybe have malignancies, and I think we're picking up a second population of patients who are saying, I'm too sick to eat, I've got a low sodium intake, and it's picking up that their life expectancy is poor. So a little bit of information there. Finally, don't forget that about 1% of the population has a salt-losing tubulopathy. I don't know if you remember Barter's and Gittleman syndrome from medical school. Barter's and Gittleman's are tubulopathies where patients lose salt in the urine. They end up with hypokalemia and hypomagnesemia. You think about Barter's, it's a loop disease. It's like Lasix because the defect is in the sodium potassium 2-chloride transporter. And Gittleman's is like hydrochlorothiazide, like thiazide disease, distal tubule, and it's the sodium chloride co-transporter that is defective. So these are congenital defects. The patients get hypokalemia, metabolic alkalosis. They're rare. And Gittleman's can be differentiated if you're keen, because the Gittleman's, because it's like a thiazide, right? It keeps the calcium in. They have hypocalciuria as well as hypomagnesemia. And you can see how rare these conditions are, but that's the homozygous. Heterozygotes make up about 1% of the population. And in data from the Framingham Offspring study, when they assessed for these tubulopathies with DNA analysis, they found about 1.5% of that population had those anomalies. So about 1% of our population spills salt in the urine. So if we set an adequate intake of sodium of 1,500 milligrams per day, these are the patients that really need that sodium. So it's not one size fits all, and we can't get everybody's sodium down so low. We have to worry about these Barter's and Gittleman's heterozygotes. And if you're managing many hypertensive patients in your practice, you've seen them. They're the ones who are on the hot days on our antihypertensives, get weak and dizzy. So what dietary advice should we recommend to our patients? Most people consume too much sodium. They should dial back on their sodium intake. For hypertensives, people with diabetes, chronic kidney disease, heart failure, that, depending on where you live, is about 30 to 50% of the adult population. Targeting a lower sodium intake towards that CDRR, towards 2,300 milligrams per day makes sense. If they're up above 3,000 milligrams, if they're up above 2,300, try to bring them down to 2,300. For the rest of the population, we can be more liberal. We don't want them to have tons of sodium in their diet. We want them to have a more reasonable amount, but they don't have to be 2,300. They could be in that 3 to 6 range, say 4,000 milligrams per day, or try to keep them just under that. And don't forget adequate intake, and some of our patients really can't tolerate a sodium intake under 1,500 milligrams per day. So I'll stop there. Tawfik, I've got, if you want to distribute the slide deck, I have a case that takes you through a young woman who had a remarkable amount of sodium in her diet, and people might enjoy looking at that. Or we could bring it up during the Q&A.
Prof. Tobe, I'm trying to get in.
Let me unshare my slides. There we go. How's that? No, now we've lost your voice.
Dr. Tawfik, kindly unmute your mic.
Oh, it looks like he's frozen.
Dr. Tawfik. kindly.
So while you're doing that, I'll just thanks Mohammed for the question. Is there any way to neutralize the effect of sodium intake with some other foods, like drinking a lot of water at the same time? I'm afraid not. Once sodium is in our bodies, it's going to distribute across the ECF, and our hypothalamus is going to make us thirsty, and we are going to drink that water. We are going to drink that water because we're thirsty, and then over time we're going to excrete it. There is no food that neutralizes the effect of sodium. Which is the best alternative salt in food for patients who have no kidney disease? We can give them a potassium chloride, salt substitute is quite good. But if they have kidney disease, of course, we don't want them to use salt substitute. So if you have patients who must use the salt shaker at home, patients who really shouldn't be eating a lot of salt, there's lots of evidence that salt substitute KCl is quite good. How do you gauge on average how much sodium you're consuming? The only way to do it is with a 24-hour urine. That's the only way to figure that out. And is it enough for a healthy diet to contain 1,500 milligrams per day, or should we add more cooking salt to reach above 1,500 milligrams per day? Wow. So there are groups in the world that have very, very low sodiums in the diet, and 1,500 milligrams per day is enough for all but the 1% who have these tubulopathies. So if you're really tough, you could keep people on 1,500 milligrams per day, although it's really difficult. That would mean not eating any fast foods or processed foods at all. Patient on 3 meds for hypertension and serum sodium, was low. How can we manage them? So that patient has hyponatremia. It's 4% of all patients on diuretics are going to have hyponatremia. And if they're on a thiazide diuretic, you're really stuck with that. I mean, you could dial back on the amount of free water that they're taking, but for most of those patients, you have to take away their thiazide diuretic and manage their hypertension without. Those patients are typically tea and toasters. They're typically little old women, and their protein intake is very, very low. So if you can get them to increase more protein in their diet, they're going to manufacture more urea. Their kidneys are going to have more of a concentration gradient, and they're going to be able to generate free water in their urine. The countercurrent mechanism is going to be stronger, but it's very difficult to get people to eat a higher protein diet if they're older and if they're more frail. So stopping the thiazide diuretic is really all you can do in that situation. Good. I've got through those questions. Please ask more questions. And Dr. Tawfik, do you want to jump in? And are there any other questions? Many patients face difficulties to calculate the sodium intake. How can we help them and explain to them in a simple way? 2 things to tell them. Number 1, reduce your intake of fast foods and processed foods. And typically our patients will be going to any fast food, whether it's Pizza Hut or McDonald's, or any of those places. That's where they're consuming a lot of sodium from. Bread and pizzas, that's number 1. Number 2, look at labels. Look at the label on the product and aim for something that has less than 5% of the recommended daily allowance. So in Canada, we have a product called V8, and V8 is a tomato juice, sort of a vegetable juice, and regular V8, 1 portion of regular V8 has 17% of the recommended daily allowance for sodium, but they have a low sodium version of that, and that has 1/5. That has only 2 to 3% of the recommended daily allowance. So if our patients make good food choices, they can reduce the amount of sodium in their diet. Of course, lots of fresh fruits and vegetables make a big difference as well. Are there, let's see if we've got a few minutes, maybe I'll take you through, I'll take you through that case. What would you, what would you like?
Go ahead, Prof.
Okay, so let's, there she is. And I'll just take you through. Is that showing up?
Yes. Yes.
Okay. So this is a case, a real patient from Montreal that my colleague Luc Trudeau, no relationship to our Prime Minister, who's a general internist and hypertension specialist and expert on sodium intake, put together for one of our education modules. So Lavani, she's 56. She's born in India, and she's been living in Canada for 8 years, and she's hypertensive. And her average blood pressure in the office, 158/98, and she's perfectly fine otherwise. The hypertension's been there for 5 years. She's taken some medications. She doesn't really do much exercise at all, but she gets some back pain when she's up preparing meals for a long time, and she's had her gallbladder out. Her father was hypertensive, her mother hypertensive, and she's got lots of cardiovascular, cerebrovascular disease in her family. She doesn't want to get to that stage. Here's her current meds: ramipril, hydrochlorothiazide, and she takes ibuprofen every once in a while for her back, which of course is going to make her blood pressure higher. And she likes natural products, and she imports them from India. So rock salt has to be good, Indian pickles, gooseberries. She's not very tall, weight 64 kilos, BMI 25. The rest of her exam is completely normal except for that high blood pressure. And she had no edema. So when the dietitian sat down with her to look at her diet, she has a diet that's typical of a classic Indian diet, Indian diet. I'm no expert at Indian diets. I like Indian food. And who knew that all this yummy food that is very, lots of vegetables in here, who knew that this food had so much sodium? And the dietitian calculated that in one day, little Lavani was eating 5,000 milligrams of sodium. Wow, an eye-popping amount. Again, you know, we talk about the same amount of sodium per person, but she's pretty tiny. That's a lot of sodium. So she gets counseled about avoiding canned foods, limiting sauces and condiment intakes, not to use salt freely, not to use tons of baking soda, change to unsalted butter, and more fresh fruits and vegetables. 3 weeks later, her blood pressure is down substantially. She's on the same meds, and now her meds are more effective. And now she's walking, and she's applying the dietary changes. Her weight is down a bit, and her pressure remains less than 140/90. So it just shows you that for that patient, that sodium in her diet really pushed her blood pressure up and made her antihypertensives ineffective. And so just to summarize, today my goal was to describe the role of sodium in maintaining normal blood volume and hemodynamic stability. We rely on salt. Sodium in our blood is a necessity, but too much sodium over time is harmful. By the time we hit age 60, half of us are hypertensive, and for half the population, and then you add other patients who have diabetes and chronic kidney disease. So it's not too long before about half the population really is salt sensitive, and we want to not have people eating too much sodium. And the controversy, no one is arguing that too much salt is no good. the argument is how much salt should we target, how much sodium should we target in our diet, and the argument is around how low should we go. So if we aim for those patients with chronic diseases, hypertension, diabetes, chronic kidney disease, heart failure, 2,300 milligrams a day. If they're much above that, we want to target that level. For everybody else who's healthy and well, let's leave them alone. Stay under 4,000 milligrams per day. Most people in Canada are at that level, and let's counsel them if they're really abusing sodium in a big way. So I'd like to thank all of you. Thanks, Dr. Tawfik, for inviting me to do this. This is one of my favorite subjects. Usually I'm squeezed in between the low sodium and the quotes high sodium and the sodium controversy. But what you can really see is that both groups are right. The data is the data, and we're just very heterogeneous. But I think we can all agree for hypertensives, we want to keep that sodium down around 2,300 milligrams per day. Thank you so much.
Thank you, Prof. Tobe, for your wonderful presentation. Can we have some more questions? We have 2 to 3 minutes more.
Here we've got some more.
Okay.
Many patients. Oh, go ahead.
One of the questions, is there any way to manage the hypertension that is usually 120 over 95? In other words, the systolic is the one who is high, while the systolic is normal.
So isolated diastolic hypertension is the least common type of hypertension. We usually see it in young people who have a lot of hemodynamic. They've got lots of vigorous pumping hearts, and it's not as worrisome. But if that patient has left ventricular hypertrophy on their ECG or echo, we really need to bring their blood pressure down. And because they're young and they're typically active, I like to use calcium channel blockers like amlodipine in those patients, and I find that is the most effective for that group.
Okay, one last question. Can salt intake decrease the efficacy of antihypertensive medications?
Absolutely. Just like Levani, on good medications, but it really makes them, particularly diuretics and ACE inhibitors and ARBs, it really overwhelms those medications and makes them ineffective.
Okay, by that we conclude this event. Thank you, Prof. Tobe, for your valuable time and for your nice presentation. We hope that we invite you to our future webinars, and thank you very much.
Thank you.
Okay, see you.
Bye-bye.
Bye.